It's time for the Wellness Watch. Sponsored by the African American Wellness Project and blackdoctor.org. Hosted today by Dr. Michael LeNoir. And now your host, Dr. Michael LeNoir.
Good health and welcome to the Wellness Watch. I'm your host, Dr. Michael LeNoir. I think we've got an interesting program for you today. Dr. Glenda Lewis has written a book called Focus on Your Best Health. It's a book that tells you how to deal with the healthcare system, a system that's often not fair, discriminatory, and ineffective. In the second part of our program, we're going to talk to Dr. Mack Roach. He is a world expert in the treatment of prostate cancer, especially in African American men. He is going to talk about some encouraging statistics that we're starting to see once the playing field is evened out for Black men with prostate cancer. But first, let's welcome Dr. Glenda Lewis. She is a frequent visitor here at the Wellness Watch. She is an internist who practices in the Bay Area, a very distinguished internist and author of the book, Focus on Your Best Health. You know, when we enter the healthcare system, well, let's talk about it a little differently. You know, whenever they talk about African Americans, they're always telling us about all the things we don't do well. We don't exercise. We weigh too much. We live in bad places. Well, we all know that that's kind of a thing that they do without giving any kind of credibility to other factors which may result in poor incomes for African Americans. My concern today and our concern today is not what you're doing, it's what they're doing. We're going to talk about what we call healthcare disparities, how you're treated in the healthcare system and how that impacts outcomes. No better person to be with us than Dr. Glenda Lewis. Welcome to our program.
Thank you so much, Dr. LeNoir. It's an honor to be back on your program and with your audience. I would love to jump right in, if it's okay with you, to start to address that.
I got a couple of questions before we start jumping.
Okay.
And I know when you jump, you jump.
All right.
Well, what was the moment you decided to write the book, and why did you give it this name?
The decision to write the book was probably about 2 years before we really wrote it. And it was, the book actually was released in late 2013. And so the decision was around 2011. It was after about 10 years of really advocating for friends and family. My co-author and I, Dr. Spriggs, recognized that throughout our lives, we continued to just get phone calls from friends and family about things that seemed to not be understood in an emergency room visit or in an office visit. And when we intercepted or interceded, whether we spoke with the doctor or whether we spoke with our friends that were ill, and just gave them some pointers and some tips on how to navigate the system, it appeared that their healthcare changed. So we just made a decision that we couldn't reach the whole world by telephone, and that it would be best to put this information in a book that would help to teach individuals the tools on how to navigate through the medical maze.
You know, most people don't recognize how important factors are when you get into the hospital that have nothing to do with you or your disease. Give us an example of the kind of situation that motivated you to write this book.
Well, when I found out that as a parent and as a wife, that I was engaging in these situations with medical professionals for my own family, it was very obvious to me that if these kind of things were happening to my family, then, oh my goodness, what was happening with those that did not have the medical knowledge and experience? So just very basic examples. My mother was hospitalized at one point, and just simple things like the IV that goes into your arm was placed, and a bottle of fluids were hung to run in over 6 hours, but instead it ran in over 30 minutes. Imagine what that might do to your lungs. Is that an okay thing? And when I was there at the bedside, it appeared that it was just kind of no big deal. Oh, well, what happened? Another situation was with my child who was actually having abdominal pain. And I literally had to kind of convince the doctor to take my son to the emergency room to have his appendix removed because nobody believed that he had an acute appendix. You just pushing and nudging and fighting and asking more and more questions. And that's very, very difficult for a person that is actually ill. Fortunately, I was there to be his advocate. But these types of things just really shouldn't happen. And you wonder sometimes, why does this happen? In my situation, I had actually just come back from Africa for a work-related trip, and the hospital seemed to be convinced that maybe he had some kind of parasite because maybe he had traveled with me to Africa, even though I told him no. But just the basic classic presentation was something I had to push and nudge. And my concern was, again, if this is happening to me and my family, what is happening to others? So you look at the outcomes sometimes of patients that look like us, and you wonder why they are in these situations, and we don't have the knowledge. We don't have, and sometimes we're intimidated by physicians when you go into a hospital setting. So part of the information in our book is to equip you with the knowledge and the information so that you can step right out there, ask the doctor the questions. Don't be afraid to ask questions. And if things don't seem right, maybe they're not right. Keep asking the question until you get the answer that makes sense.
And everybody out there who's Black or who's a person of color or women have had this experience. The experience of going into a system that's supposed to gather you in, get a sense of what's wrong with you, and subsequently manage you so that you leave. But what I want our audience to understand is there are a lot of other factors. I mean, from the person at the desk who calls you by your first name, from the fact that the doctor pays no attention to you. I mean, there are several factors. Speak to us a little bit first about unconscious bias, because many of us don't recognize when we go into the system that the system already has a preconceived notion of who you are and treats you that way.
Absolutely. It really does start right at that intro. I mean, just the simple way of getting an appointment. Getting an appointment sometimes can be major. You can call in and you're not known, and you try to make an appointment with your symptoms and you're put off for 2 weeks. The average patient will think, oh, well, I guess my situation must not be that difficult. But someone else can call in and give 1 or 2 buzzwords, and they get right to the front of the line and get that appointment same day. And, I have to say, sometimes the office looks at the insurance. It's awful to admit it. But the point of the matter is that those things are looked at. The other barrier that we sometimes have is we buy into the high deductible plans because somebody convinces us that that's a really good thing to do. And then you've got to have $5,000 to pay out of pocket before you can get some of these services done. And therefore, you then make that decision to say, oh, my goodness, who has that? Some of the other barriers are just an expectation that whatever the doctor says is okay. You're just going to accept it. I've had another recent situation, just very unfortunate, and this was obviously in a family of color, where a patient was diagnosed with a terminal illness. And the oncologists were deciding between whether it was breast or whether it was ovarian. I mean, how is it that a medical provider can't make that decision definitively and tell the patient? So you tell the patient one day they've got cancer of the heart, of the lungs, and then the next day, oops, well, we've got now cancer of the ovaries. I mean, those types of things. And I dare say that I wonder that if this is only happening in communications in environments where there are people of color, where there's an expectation, we don't know, we don't understand, and they'll just give us any information. But I will tell you this, that when you bring someone into that room or on that telephone and you start having conversations with that doctor, and you have someone that can speak the language that the doctor is speaking, or even just asking basic questions, your care will change. Your care will absolutely change. The other thing that's happening in hospitals now is that there are incredible vacancies. And so the staffing is just all over the place. So nurses are being required to take care of more patients. And so you better be there for your loved one to be able to raise those questions. If it doesn't sound right, you need to raise a question. Dr. LeNoir, had another situation in the last 8 months where, when you come into a hospital as an old Black person, and old, I'm talking about 70 years old, because they look at you and want to try to say, do we want to resuscitate this person? They're 70. You're just written off. So if you're over 50 years old, you better have a family member there saying this person is active in the community. And yes, we want everything done to make certain that their care is the best.
Yeah, and don't let this COVID thing throw you off, because what happens is that if you are in a situation like that, then you got a phone. And when you pick this is called an advocate. And when you pick an advocate, don't pick your brother or your cousin who doesn't know anything about health. You find somebody in your stream of consciousness who knows something about health, and so that that advocate can understand what's going on when you have a problem and be able to respond. In this day and age, so many of the beds are filled up with people who have COVID. And so consequently, you're going to go to the emergency room, you're going to lie around for quite a while. And, I'm not going to say, I don't want to say exaggerate your symptoms, but certainly let them know that whatever symptom you have is causing you a great deal of discomfort, because it's going to be 2 or 3 hours before you see the doctor. They trick you by putting you in there and putting that, taking your temperature and then, closing the thing down. But then after that, you don't know what's going to happen. So you need to take a phone, because they're not allowing you to go in there. But you need to have an advocate whenever you go into the hospital. And tell us what would happen. Tell us some of the ways in which we can avoid not only the advocacy issues, but the navigation issues.
So, one of the things that I've decided to adopt this year is getting back on track. And getting back on track means get back in tune with the things that you should have been doing in 21 and 20. So that means know your numbers. Find out exactly what it is you're supposed to be getting done. If this is a year for your colonoscopy, if this is the year for your mammogram, know that this is, and be persistent about that. Don't let somebody tell you, oh, we're booked up, or, oh, we don't have an appointment and we'll get back to you. You've got to follow up on that yourself. One of the other things that's really important for you to do is to know your numbers. Be knowledgeable about what your blood pressure is, what your oxygen saturation is. As Dr. LeNoir mentioned, you can go into the emergency room, and if you look like you're okay, you will then also be pushed to the back. But know what your normal oxygen saturation is. So some of this you've got to own. You've got to know what your insurance is. You've got to know what hospital is covered by your insurance. You've got to know where the centers of excellence are in your community. If you are having stroke symptoms, you should not go to a hospital that does not have a stroke center. If you're having chest pain, you should try to go to a hospital that has a cardiac unit. So some of this is just, we consider it basic knowledge. But now as a patient, back in the old days, you went to the doctor and everybody kind of took care of you. Well, now it's important for you. You've got to know your numbers. You've got to know your insurance. You've got to know, and you also need to be able to understand a little bit about specialty care. If you are seeing a primary care doctor and you're not comfortable with the responses or the progress of your condition, don't be afraid to ask for a specialist. I mean, honestly, a primary care doctor, a good primary care doctor, should know when they're out of their league. But don't be afraid to ask for that. So in navigating this system, you've got to be able to know all of these things in order to ensure that when you get to the front door of that patient, of that doctor's office, that you're then going to be then the clock starts all over again, because you're in there with a brand new provider, and you've got to declare yourself as an articulate person that cares about their health. And as you pointed out, Dr. LeNoir, all of our problems are not because we eat too much or we live in a different community. It's not all related to that.
Well, I want the wellness. Well, let me just say, we're talking to Dr. Glenda Lewis. She's the author of Focus on Your Best Health. This is you got to have this book. There's no question. At the end of the day, you have got to have this book. And if you want to know how to get the book, then you have to go on our website at aawellnessproject.org, and there will be sufficient information for you to know how to order the book. But what she's saying is so critically important to all of you. You just have to, we care. We're doctors. We're there. We see these mistakes that are made. We see this disrespect that goes not only to them, but they try to put that disrespect on us as well. So we are telling you things that you need to know. And the book, Your Best Health, is a way for you to navigate the system successfully. Let's go back to your discussion on specialists. When a doctor refers you to a specialist, you look that specialist up. You look and see what the ratings are. You look to see how many times he's done a procedure or how much expertise he has in something. Sometimes they may send you to their cousin or their neighbor or the guy next door, but you want to know who your specialist is.
Agreed. And, we used to say years and years ago that the best referral for when I was in private practice many years ago, we used to always say the best referral came from another patient, not necessarily from another doctor. Talk to your friends, find out who they are seeing as cardiologists and rheumatologists and pulmonologists and infectious disease specialists, because generally, and I'm assuming that, and I'm specifically addressing people of color, there is a chemistry. You can have all kinds of problems, but if there is no chemistry and there is no trust in that visit, then it's very, very difficult to follow the recommendations from that doctor. So yes, you need to look the doctor up. And you need to ask that doctor questions. I think one of the most important things that we really talk about in the book, in addition to being knowledgeable, is don't be intimidated. This is your body. You know what's going on. There are so many times when patients come in and they are a little vague because they're not clinical. They don't necessarily understand. But do your best to try to quantify your symptoms as much as you can. I've had this pain for the last 6 months, and it's worse in the morning than at night, and I graded a 6. So put some parameters around it, objective as much as you can. But don't be afraid to ask the questions, and don't be afraid to question the doctor that if information that is coming to you doesn't make sense. I had another situation where a family member was given a diagnosis of breast cancer, but no mammogram had been done. No mammogram had been done. There were no masses in the breasts, but the individual had been given that diagnosis. Made no sense. And then, of course, you get an advocate involved and you raise the question. Well, where's the mammogram? Was the response. Oh, let me.
We're doctors. I'm telling you, you're getting this straight from in my case, straight from the horse's mouth here. I mean, we see this all the time. If you're not forceful, if you're not organized for your visit, if you don't ask the questions, and don't be afraid to change doctors if you're not happy with the kind of service that you're getting. All of this is in the book, Your Better Health. I would say to you, if you have to have one thing beside the Bible, you got to have the Bible. If you have any other book beside it, you must get this book, Focus on Your Health. If not just for you, for your family. You can get the book by going to the website at aawellnessproject.org. Dr. Harris, do you have a final word for our audience that I hope is listening carefully to what we're saying?
Well, yes, Dr. LeNoir, I would like to just simply say to the audience that, as has been said by many others before, your health is your wealth. And this is the year that you must get back on track. COVID is here. It's going to be here for a long time. Don't let COVID be the reason why you don't take care of yourself. Don't let COVID be the reason why you don't get a mammogram timely, a colonoscopy timely, your eye checks and visits timely, blood tests. You must take charge of your health and get into the driver's seat of this situation and recognize that you are the one that is responsible for making sure that you get the best care. And finally, don't hesitate to identify an advocate. When you get ready to have your taxes done, you usually go to a CPA. When you get ready to get your car taken care of, you don't tinker up underneath the bottom. So don't be afraid to spend a little bit of money if you need to get a private advocate, and get an advocate, because it will be well worth your investment, because it's all about you and your health. So I thank you for this opportunity. I ask that you all please go out and purchase our book, Focus on Your Best Health. I promise you, it will be not something that's left on the shelf, but it will be something that will be utilized for you in 2022.
Yeah, I certainly hope, Dr. Harris, that people appreciate the things we've been talking about. Always a good guest, always never enough time. Thank you for joining us on this issue of the Wellness Watch.
Thank you, Dr. LeNoir. It's an honor to be here.
Well, thank you, Dr. Harris. As I've said, how to get this book will be featured on our website, aawellnessproject.org. That's aawellnessproject.org. Well, now let's talk with Dr. Mack Roach, the world's experts, that I've said, in prostate cancer and the treatment of prostate cancer in Black men. He is a radiation oncologist, professor of radiation oncology, urology, and cancer at the University of California, San Francisco. His work his work with African American men, his research and studies are recognized worldwide. So thank you for taking the time out of what it must be a very busy schedule, Dr. Roach. My first question to you, Dr. Roach, is that it seems like in the literature over the last few months, maybe the last couple of years, that there is an impression that Black men do better with prostate cancer if all things are even. And let me just say this again. It seems like from the literature that much of the information suggests that Black men with prostate cancer do better than white men, all things being even, especially in the area of radiation.
Yeah, 20 years ago, all the literature said prostate cancer is inherently more aggressive in Black men. And I was right, actually it was 30 years ago, and I was writing papers saying, no, it's not, no, it's not, no, it's not. And I was describing the literature that said, that the results were the same for both. I think the most important thing is not to focus on race, is to focus on quality of care. And so you do see some studies recently that suggest that African American men do better, especially with radiation. We've actually published a paper recently that suggests that. But the differences are very small. And the differences could be explained by some type of selection bias, like which kind of Black men tend to go in studies and participate in clinical trials. I think the bigger problem for African American men is trying to understand why prostate cancer is more common in African American men. That is the single most important thing that we need to focus on. We have established long ago that if Black men get the same quality of care, that we have the same outcomes. And so I would argue that our outcomes are similar. Some studies may say we do a little bit better. Some studies may say we do a little bit worse. I wouldn't quibble about that. I think the more important thing is quality of care is important. Frequently, we don't get good quality care. Frequently, if there's an operation performed, it's performed by the resident. The radiation results are interesting because Black men more frequently prefer radiation. And that's partly because surgery is associated with a higher risk of incontinence. Surgery is associated with a higher risk of erectile dysfunction, that is sexual dysfunction. And the quality of life is better generally with radiation than with surgery. So it's not surprising that Black men, when presented with that type of information, say, if I have a choice and I can be cured of prostate cancer without losing my sexual function, I'm going to be biased toward wanting to have radiation. And so my take home message to Black men is that we do at least as well as everybody else. And we have to be very careful about what we decide in terms of what kind of treatment we want, and to ensure that Black people get good quality care.
While I have an opportunity, I'm going to take advantage of your knowledge. When I pulled up Black men and prostate cancer, there were a couple of things that come up first that seem to always come up. And one of them is, should Black men be screened more often for prostate cancer? That's one of the issues. And what types of screening do you recommend? Is the digital rectal still part of the process?
I don't think the real key is frequency. I think the first question is, at what age should you start? Okay. And then I think that, so the American Cancer Society recommends that you start screening in general at age 50. And then if you have a family history or some risk factor, you go down to 45. And then if you have, and being Black is a risk factor. And if you have a family history, you might want to go down earlier. I started screening myself at age 35. Okay. And I think that if your initial PSA is very low, so the normal PSA is 0 to 4. But if you're a youngish man, 45, 50, in that ballpark, and your PSA is more than about 2.5, you need to be watched more carefully. But when you say the normal range is 0 to 4, you got some men walking around with a PSA of 0.1 or 0.2. These are very low values. If you have a very low value, you probably don't need to be screened as frequently. So in the past, we used to talk about screening people every year. And I think that if you have a very low PSA, you don't need to be screened every year. You can be screened every 2 years, every 3 years, or whatever, depending upon your age and the circumstances. And I think the other big problem that we have is that the American Cancer Society and some other societies recommend that before you screen, you should discuss the risk and benefits of treatment. And I totally disagree with that. I don't think that a primary care doctor understands the risk and benefits of treatment. And I think that even an expert like myself, you don't understand the risk and benefits of treatment unless you know whether the person has low risk prostate cancer, intermediate risk prostate cancer, or high risk prostate cancer.
Yeah, can I ask another question? Has the MRI replaced the biopsy?
No. No, the MRI, I mean, when you talk about a test, so when you screen people in the population, if you screen 100 men, 95 men will have a normal PSA. So you don't want to take a $2,000 or $3,000 or $4,000 test and start doing it on people instead of a biopsy or instead of a PSA either. If you have a PSA that's very high,
Right.
then
And that's what I'm talking about.
Was that?
And that's what I'm talking about.
Okay, so if you have a high PSA, so let me put it to you this way. I was on a panel at the National Cancer Institute made up of experts. These are urologists and radiation oncologists who do prostate cancer stuff. And they were asked, what would you do if it was you? You have an elevated PSA. And everybody said, I would get an MRI first and then do the biopsy.
Right.
On the other hand, the problem is that the insurance companies and places like Kaiser are not going to allow you to get an MRI in most cases before you've had a biopsy.
So is that right? Is that the way to do it optimally?
Well, in the ideal world, before a youngish man gets a biopsy, it would be desirable to get an MRI for a couple of reasons. One, after the biopsy, it compromises the imaging of on the MRI. The MRI, sometimes it won't show it. There'll be hemorrhage from the biopsy, so you can get artifacts. That's number one. Number two, sometimes the cancer is located in an unusual place in the prostate. So when you do a prostate biopsy, you sample about 1% of the prostate. So you could take a man that has an elevated PSA, you can do a biopsy, and the biopsy comes back negative. You say, don't worry, you don't have cancer. On the other hand, if you did an MRI first and the MRI shows, oh, the cancer is in the front of the prostate instead of in the back of the prostate where it normally is, then you're less likely to miss the cancer. So there are studies where they've taken patients and done regular biopsies without MRI or biopsies preceded by MRIs. And if you do the MRI, and especially if you do an MRI fusion biopsy, you're less likely to find insignificant disease and more likely to find significant disease.
You know, what's interesting though is that most of my friends who had, we didn't come along at the soon. We came along too late to get spared the digital rectal and these repeated biopsies. I think many more men, I think, would be engaged in their prostate cancer diagnosis if you didn't have to do so many biopsies just to validate an existing PSA. And if the MRI does that, I would say that this may be a big step.
Well, you got to bring the price down, though. I mean, I think part of the problem is our healthcare system.
Right.
In other countries, it's less expensive, and the problem is that if you have a test that costs $3,000-$4,000 to do,
right,
you don't want to keep doing. There's pushback from insurance companies, so we need to make the MRIs less expensive, and that can be done.
Another question is, are we throwing out the digital rectal? Is that gone?
Well, during the pandemic, it has gone because most of the patients I see in consultation for prostate cancer, I do a Zoom consult rather than seeing them in person. And so I can't do a digital exam. And if they've had an MRI, many of them have had MRI and biopsy, then the digital exam isn't going to add a lot because the MRI shows the anatomy better than my digital exam. It can show it. So it's sort of during this pandemic, it's really changed the way that people practice medicine.
Yeah, I would share with them.
I haven't met anybody who likes a digital exam yet. And I see a lot of patients, even in San Francisco. I don't see anybody that wants a digital exam.
Well, it could be a screening study if you like it. But one of the things that I'm grateful for is because my prostate cancer was validated by a digital rectal exam.
Yeah, it happens, but 75% of men with prostate cancer have a normal digital exam.
I got you. Well, one final question. When we talk about options, obviously there are surgical, radiation options, all kinds of options. Is it less important or is it more dangerous for African American men to get active surveillance?
I don't think so it depends on how low your risk is. So there are some doctors that will recommend active surveillance in low volume, intermediate risk patients. I don't happen to be one of them. So I think that if you're well selected for active surveillance and you've had an adequate workup, adequate biopsy, especially if you've had an MRI. So if I have a very young patient and they've had a biopsy that suggests they have a low-grade tumor and their MRI confirms it, then I feel very comfortable following them closely with active surveillance. I think the data that suggests that African-American men are higher risk for active surveillance is problematic, meaning that it's not definitive. And I think that African-American men are still candidates for active surveillance, just like everybody else.
So to kind of conclude our discussion, you're saying to me, and I think African American men can take some consolation in the fact that no matter what the situation, all things being equal, we do just as well in treatment as everybody else.
Absolutely, no doubt, no question. And the study that you're alluding to that says Black men do better, I'm okay with that. Okay, don't get me wrong.
Really,
okay?
yeah.
We need to do better. We need to do better in something else besides the NBA and stuff like that.
Right.
Yeah.
Right. So, I agree. All right. Well, thank you, Dr. Roach, for taking time out in your busy schedule to let our audience on Doc and Dean know what one of the world's experts, I mean, not the world's Black experts, one of the world's experts in this area thinks about what's going on.
Well, thank you. Thank you for allowing me to be involved.
All right. Take care.
Okay. Bye-bye.
Back again to continue to update us on the progress we're making in taking care of Black men with prostate cancer. So now I'd like to thank our guests. This time moves by pretty quickly. But most of all, I'd like to thank you for joining us on this edition of the Wellness Watch. We'll be here every Wednesday at 6 Pacific Standard Time, and we'll run other times on blackdoctor.org. We appreciate you. Remember, health is your biggest asset. We'll talk again.